Carolina, and I'm really excited to welcome you all here to our panel this morning. We're talking about federal and state opportunities in home visiting and parenting education, and have a really wonderful panel of experts to help us talk about this and explore the issues. We're going to be talking about Medicaid, MIECHV Reauthorization, Family Connects pilots, and the Family First Prevention Services Act. Our panelists are going to provide us with some updates on these topics and introduce themselves to get us started. We'll have a conversation to discuss areas of overlap, collaboration, and future opportunities to help us think about how we expand and scale home visiting in North Carolina. So without further ado, I'm going to turn it over to Rebekkah Cook, and she is going to start our conversation talking about MIECHV.
Thank you. Thank you very much. Good morning, everybody. My name is Rebekkah Cook, and I'm the Professional Development Coordinator for the Maternal, Infant, and Early Childhood Home Visiting Program, also known as MIECHV. Next slide. The Maternal, Infant, and Early Childhood Home Visiting Program helps states, territories, tribal entities to develop and implement evidence-based voluntary home visiting programs to improve the development, health, and well-being of at-risk families with young children. MIECHV is a federally funded program by the Hirsch, also known as the Health Resources and Services Administration. And the MIECHV program emphasizes that 75% of federal funding must go to evidence-based program models, home visiting models, meaning that funding must go to programs that have been verified as having a strong research basis. Evidence-based programs funded by North Carolina MIECHV include Healthy Families America and Nurse Family Partnership. By law, grantees must demonstrate an improvement for eligible families participating in the program in the 6 benchmark areas as seen here on this slide. Next slide. North Carolina MIECHV consists of 7 sites. Starting in the western part of the state, we have Buncombe County Nurse Family Partnership. We have Blue Ridge Healthy Families, Catawba Valley Healthy Families, and Gaston County Nurse Family Partnership. Moving east, we have Durham County Healthy Families and the Northeastern North Carolina Nurse Family Partnership at Halifax Community College and Robeson County Nurse Family Partnership. There are a total of 15 counties funded by MIECHV currently. In fiscal year 2020, North Carolina MIECHV enrolled 1,009 participants or 561 households and completed 7,220 home visits. Here's some more of North Carolina's data from fiscal year 2020. Next slide.
Hi, I'm Greer Cook, the MIECHV Program Manager, and I'm going to talk about the MIECHV reauthorization this morning. So, current MIECHV funding will expire on September 30th, 2022. Some of the goals for the reauthorization include increasing MIECHV funding by $200 million over 5 years for a new funding level of $1.4 billion, to double the tribal set-aside within MIECHV from 3% to 6%, to continue to allow virtual home visiting as an approved option for service delivery, and finally to provide $150 million in emergency pandemic-related funding. Some of this funding could be used for training home visitors to deliver services through technology that enables home visits from a distance. This also will allow for the purchase of tangible needs for families, such as food, diapers, and formula. We are hopeful that the MIECHV reauthorization will continue to provide needed services for families in North Carolina. And that is the end of our presentation.
Want to go ahead, Deborah?
Yep, thank you, Sharon. So good morning. My name is Deborah Day, and I am the Community Prevention Programs Administrator at the Division of Social Services. And I want to talk to you about 2 of our federal funding streams. The first one is our community-based child abuse prevention that we receive from the Children's Bureau at the Administration of Children, Youth, and Families. This is federal funding that is designated for primary and secondary child maltreatment prevention. So that means that a family cannot yet be involved in child welfare services. North Carolina offers home visiting and parent education services that build protective factors. The protective factors are parental resilience, social connections, knowledge of parenting and child development, concrete support in times of need, and children's social and emotional development. the programs that, and I'm sorry. And then the other thing, how could I forget? The other thing we do besides direct services that focus on protective factors, we also use this funding source to support Prevent Child Abuse North Carolina, who does a lot of our public awareness campaign work, including April is Child Abuse Prevention Month, which is right around the corner. They also do a lot of resilience screenings for us. They help with protective factors and connection matters trainings, and they also offer online courses for community members and professionals. What is prevention and recognizing and responding to suspicions of child abuse? So there's a lot that goes into this. Another thing that we contract with Prevent Child Abuse North Carolina to do is support our professionals through training, through the Prevention Action Network, and through implementation support for our Incredible Years Strengthening Families program and Circle of Parents programs. So this funding is relatively small. It's about $1.6 million each year, but we braid it with some other sources. We braid it with our federal Title 4B2 money, which is promoting safe and stable families, and also our state North Carolina Children's Trust Fund. So with that, we're able to fund a variety of home visiting and parent education services, including the three I just mentioned: Incredible Years, Strengthening Families, and Circle of Parents. In addition, we our grantees also offer PPP level 4. They may offer that as a group, or they may offer individually in home. And then in terms of home visiting, we offer parents as teachers, parent-child interaction therapy, and attachment behavioral catch-up. One of the caveats is that the American Rescue Plan Act gave North Carolina a one-time bonus of $7 million as an effort to help alleviate families' stress that they may be experiencing from COVID pandemic in particular. And so Governor Cooper's plan on how to use this particular CB cap American Rescue Funds is to do more ACEs screening, more protective factors work, and more resiliency work. It is to expand our primary prevention work, and it is also to offer concrete supports to families: food, rent, utilities, diapers, just like Greer said in MIECHV. Next slide, please. Okay, so I did want to talk to you about major federal child welfare reform that happened recently, the Family First Prevention Services Act. Unlike these other funding streams that I just talked about, this is considered tertiary prevention. So this is serving families who are at imminent risk of having their children placed out of their homes. So they're already involved in the child welfare system, and child welfare traditional services are not necessarily enough to prevent a foster care placement or a group home placement. So these services are divided into different categories: mental health services, substance use disorder services, and in-home parenting. Like they talked about with MIECHV, all these programs must be evidence-based programs, and the federal government set up their own clearinghouse for this particular funding stream, the Title 4E Prevention Services Clearinghouse. So any program that a state needs to provide, is allowed to provide, must be on this list. And they divide this list into well-supported, supported, and promising. So North Carolina is using a phased approach. We had a 2.5-year planning process with lots of stakeholders. And we decided it was in our best interest to do this slowly. So we are starting with Home Builders, which is an intensive family preservation service that's in home, and Parents as Teachers, which serves our youngest children birth through 5. Both of these services are rated as well supported on this clearinghouse, which makes them a little bit easier for states to implement. Our goal is to implement these services statewide within the 7 social services regions. And this funding stream also requires a rigorous evaluation and/or a continuous quality improvement plan. Once we get these two programs up and running, the state also plans to implement PPP Level 4, multisystemic therapy, and methadone maintenance treatment in order to reach the mental health and the substance use disorder needs of our clients involved in child welfare. So I'm going to hand it over to Kaylan Szafranski.
Good morning, y'all. It is so great to be here with you this morning. I am going to walk us through some of what's going on with Medicaid. So next slide, real quick. My name is Kaylan Szafranski. I am the Health Policy Director at MIECHV. We are a statewide policy organization that really looks at policy across all systems that can benefit children and families. And so before I kind of jump into where we are specifically with home visiting and parent education and Medicaid, I did want to just level set quickly with an overview of what has been happening with Medicaid, because I know there's nothing more exciting than talking about Medicaid at 8:30 on a Tuesday morning. So as you probably know, we have recently begun the transition into managed care, meaning that there are private organizations that are overseeing the implementation of Medicaid in North Carolina. So we have moved from a fee-for-service model where folks, providers were paid for services rendered kind of ad hoc and not under the housing of a managed care organization or a prepaid health plan, as we're calling them for the standard plans that have already been implemented. So just wanted to make sure we were all on the same page with that. So next slide, please. So as I am sure if you have gone through the arduous task of billing for services under Medicaid, you might feel like this puppy because it is not easy. And our transition into managed care right now is still working out a lot of kinks. So you might find that some plans, some of the PHPs are a little bit easier than others to request reimbursement. But just a quick reminder that Medicaid reimbursement for home visiting services requires specific eligibility for both the individuals on Medicaid to make sure they are in a program that is eligible for these services. So there are some limitations depending on how people come into Medicaid, whether it is for being pregnant, whether it is for a specific diagnosis or disability, or income eligibility. There is a federal requirement called EPSDT, Early Periodic Screening, Diagnosis, and Treatment. You understand why we call it EPSDT, because that is a mouthful. And basically that says if the service is deemed medically necessary by that child's provider, the state has to pay for it through Medicaid. So I wanted to flag that because while we know that the way the system currently works is they kind of break up services that can be reimbursed. So not everything is a whole package for reimbursement, but EPSDT can help fill in those gaps. The one caveat to that is that you have to request EPSDT and prove that it's medically necessary, which can delay services. The other big kind of piece of this is services must be evidence-based, and we talked a little bit about that already, or other qualified services. So the state can decide what services they will reimburse based on the criteria that is outlined in the very thrilling state Medicaid statute that outlines all of the services that they consider evidence-based, and that can be found on the DHHS website. There's also another piece of this, of course, in that billable services have to be provided by Medicaid enrolled and eligible providers. And so one of the things that I know we at MIECHV really want to look at is what do they mean by eligible providers and how can we extend that? Currently, degree requirements apply, but we know that there are incredibly thoughtful and well-poised providers out in communities that are able to do this work, where they are currently not eligible for Medicaid reimbursement. And we think that there are ways that we can support our community-based providers like promotores to help make these connections to home visiting and get provided for those linkages. So that's something that is kind of in the back of our minds. And then, as I mentioned, the headache of billing itself. So billing codes and procedures and eligibility can be different based on all of these eligibility programs. Counties can deal with enrollment a little bit differently and flagging within their system what program you are. So we have seen some issues with that based on counties. And then of course, every prepaid health plan has their own way of going about billing and reimbursement. So it is quite an arduous system. So when we think about what our opportunities are, I think a lot of it is addressing how we are paid and how much we are paid and who is paid for these really critical services that we know impact the life course of this child and this birthing parent. So we really want to make sure that we are taking away as many barriers as possible. And so next slide, not to belabor the point, but I do think that the biggest thing that we can do is we need y'all to be advocates. You are the closest to the issue. You have the right ideas for the solution and how to open up these services to more people and make sure you are paid adequately for them. And we really need your voices in that, right? The General Assembly gets to determine our purse strings and how the state uses that, including what DHHS does. And so I think I would be remiss to say that we really do need folks to weigh in. NC Child has our Child Advocacy Network. We would love for you to join that and help lift these issues up with your voices, but also you are more than welcome to reach out to your electeds in your area and really help them understand why these services are so critical and why things like billing and reimbursement can be real barriers to access, especially for families who need these services most. So also any questions or anything you need, feel free to reach out. My email is right there. And I will pass it over to Mary Scott.
Thanks, Kaylan. Good morning, everybody. I'm happy to be here. I am Mary Scott. I work with the North Carolina Partnership for Children, and I'm here today to talk about the collaboration on a pilot project between the North Carolina Partnership for Children, or NCPC, and Family Connects International. But I did just want to start and say that I'm also a mom of two and was fortunate to be able to receive home visiting with my first child. And even with an early childhood background and feeling like I knew what I was doing, I think what took me by surprise was when the nurse home visitor looked at me and said, "How are you doing?" And I just felt like it was this tremendous lifeline for me I was trying to hold it all together. And so to be able to have someone come in my home and offer that support to me was really incredible. So now I'm happy to be here and advocate for home visiting and parenting education services because I feel like it's a way of checking in and really supporting the whole family. So happy to be here and share a little bit about this project, one of the projects that I'm working on. And so as you may know, NCPC is the organization that provides funding, resources, and support for the 75 Smart Start partnerships covering all 100 counties in North Carolina. And we received the preschool development grant funds to pilot the Family Connects universal home visiting model in 8 counties throughout North Carolina to implement and then hopefully to consider statewide expansion. So a quick overview, this collaboration between Smart Start and Family Connects International enables us to leverage Smart Start's deep roots in each of the communities with the strength of the Family Connects evidence-based model. So for those who don't know, Family Connects is a universal home visiting program for new parents with up to 3 free home visits in the first 12 weeks after having a baby. So registered nurses go into the home or via telehealth and visit with the families of newborns. They provide health checks for both the infant and the mother or parents. And then the nurse is trained to make a systematic assessment of the family's strengths, risks, and needs, and then to connect them with resources and supportive services after that home visit. And if you want to learn more about it, this afternoon, there's a session, I believe at 3:15, where Jess Reinholtz from Family Connects will be talking a little more about the model. The overarching goal is to connect families of newborns with support and connection to resources to provide the nurturing that they need. And for this PDG pilot, the focus is on rural counties where there tend to be less services available. And also there's an evaluation component that we're doing with Duke to consider the effectiveness of the virtual delivery of the model, since many of the home visits are happening via Zoom or phone right now. And next slide, please. So this is a map of the Family Connect sites. There were 3 sub-grantees to receive funding through this PDG work. And so you can see, hopefully you can see on this map, the different areas that are being covered. So in the Northwest, you've got the Children's Council, Smart Start Agency. So it's called Family Connects Northwest, covering Watauga, Ashe, and Avery. And then you've got Family Connects Henderson, which is hosted by the Smart Start Partnership for Children in Henderson, covering both Henderson and Polk counties. And then we have Family Connects Southeastern, hosted by the Partnership for Children of Cumberland County, serving Cumberland, Robeson, and Hoke. All right, and then just the opportunity and vision that we have here is the goal is over the course of 3 years to serve approximately close to 10,000 families. And the goal is to connect those families with comprehensive services in their communities, and also to connect them with further home visiting and parenting education. So I think that's a great opportunity that we have here now to demonstrate the power of universal home visiting to improve outcomes for children and families, and then to pave the way for further expansion across the state, which is the overarching goal, really, to take this statewide so that every family has access to home visiting after the birth of a baby. So thank you, and I will pass it back to Sharon.
Well, thank you all so much for giving us a great introduction to all of these programs. Now we're going to start our panel discussion. And our first question really focuses on the fact that these programs and initiatives that all of you just talked about hold incredible promise for North Carolina's children and families. What do you think is the greatest opportunity within your area of work? And how can these initiatives help expand access to home visiting and parenting education in North Carolina? And we'll start with you, Rebekkah.
Okay, so as Greer previously mentioned, MIECHV is currently in the reauthorization phase to continue funding for 5 more years. If reauthorized, North Carolina MIECHV will be able to continue serving North Carolina families in the current 15 counties. Both the MIECHV funded home visiting programs in North Carolina meet families where they are and cater to their current needs and supports. Because of this, MIECHV does not see itself as a one-size-fits-all, so programs are able to modify their visits accordingly. Both Healthy Families America and Nurse Family Partnership value that all parents are the experts of their children. Home visitors help guide families as a whole unit in accomplishing the goals the family has chosen to work on, as well as help families navigate through systems, life, supports, or whatever the need is currently at the moment. They also support healthy pregnancy practices, provide information on topics such as breastfeeding, safe sleep, preventing unintended child injuries, and nutrition. Home visitors encourage early language development and early learning at home. They teach positive parenting skills like reading, playing, and praising good behaviors. Home visitors work with the caregivers to set goals for the future and continue their education or find employment or childcare solutions. And they also connect with families and other services and resources in their community. Home visitors and families develop strong relationships and trust through meeting regularly and addressing the family's needs. So going back to MIECHV reauthorization, it's imperative that policy leaders are well educated about the importance of home visiting and the services offered to the families.
Greer, did you have anything to add to that? No, okay. How about you, Deborah? What are the opportunities that you see?
as I mentioned before, the Family First Prevention Services Act is a major transition from the federal government. So one of the most important goals, besides preventing repeat child maltreatment, is to prevent out-of-home placement for children. And every state is evaluated on that from the federal government. But at the same time, the way the federal government was funding these state services, states got paid for every child they had in out-of-home placement for every day. And so there was like a real disconnect between the goal and the way that folks were reimbursed. And so Family First is an attempt to align that. It shifts the primary goal for Title IV-E funding from paying for foster care and group homes to paying for evidence-based services to prevent children from being separated from their family and placed outside their homes and communities. So while I would not consider this primary, secondary prevention, I think it is more of an intervention. In the child welfare world, it is considered tertiary prevention. And the other thing, so that's a major alignment. It's really a good way, of getting states to meet their goals, is to be able to fund them for that. Again, the reasons that families come to the attention of child welfare are very consistent. They are mental health, they are substance use disorder, they are parenting issues, those tend to be the major things. And so the federal government focused their attention on funding those types of services. The other thing that's really important is Family First is an entitlement program. So instead of a set allocation, like I was describing the CB cap, it's an entitlement program. So in theory, the money is there to support the need. Every state has to provide a match. And so that might be where the limiting factor comes in. But, if instead of giving folks $1 million, if 1,000 children need a particular service, they should be able to get it and the federal government will reimburse it. If 10,000 children need this service, the federal government should reimburse it. So this means that North Carolina, as will all states, will have a reliable way to fund consistent services. The other thing is that North Carolina is really trying to make a commitment to serve families across the state, regardless of where they live. So services will be based on the child's need, not where the service is available, which is how most of our services are right now. It's more like a patchwork. So as I mentioned before, we're going to be expanding home builders, parents as teachers, and PPP level 4 to just name the parent education home visiting programs across all 7 social service regions. I'm going to hand it back to you, Sharon.
Great. Kaylan, where are the opportunities that you see in Medicaid?
Absolutely. So I think because we are in this world of managed care, there are quite a few opportunities. So managed care requires that care coordination is available to all beneficiaries. And I think to Deborah's point about this being preventative care, right? Or thinking about it in that modality, that there are increased opportunities for providers to make this linkage with the family and better integrate home visiting into their care management system. So creating a feedback loop between the pediatrician or primary care provider and the home visiting team so that everybody is on the same page with what supports they're providing these families and what things that the provider and more the medical home need to be thinking of in preparation for the next steps of this family developing, as well as holding that kind of dyadic framework at the center of the medical home. I think we are starting to slowly see how we, at least on the physical health side, think about that dyadic nature of care. But I think we can go a little bit further. And I think part of that is truly bringing home visitors into the conversation as we think about more holistic child and family centered care. The piece of that I think we are well positioned to move forward to, not just in practice, but we of course have to back it up with reimbursement, right? And so as the state is starting to move towards more innovative payment models under Medicaid, we can also start leveraging those to include quality measures that include home visiting practices. What other services are we able to support this family with? And how can we bump up the rates for all providers helping to get that kid and that family to the outcomes we're looking for? I know other states maybe a little bit more further along and progressive than we are right now, but certainly have all been in this managed care world, have been able to do this. I think one of the other big pieces, and I just saw the comment about the PHPs, I think you nailed it. So we have to do a better job of getting PHPs to not only reimburse more appropriately and a little bit more easily so that it's not so burdensome, but we also need to make sure that the providers within the networks of the PHPs are linking to these services, as well as the PHPs meeting families with these are available services to you, helping to increase that education and understanding so that families are equipped with what they're entitled to. There are federal requirements that require managed care organizations to let families know that like EPSDT is a thing, right? That doesn't mean a whole lot for beneficiaries until you start tying that to specific services. And when we think about preventative care and we think about necessary care to ameliorate and kind of triage impending potential crisis or higher need, we need to start backing that up and letting folks know what's out there, what's available, so they can have those conversations with their pediatrician, so they can be really thoughtful when they are saying, you know, I need more support, I just don't know what that looks like, and have that be what triggers more warm handoffs to these services and to home visitors. So I think there's a lot that can happen within Medicaid. Some of it is system integration, which is easier said than done. And some of it is quite literally helping to support the arbiters of our care. Right now, they're really the PHPs, in making sure everyone, providers to beneficiaries, knows about these services, how to access them, how to be referred to them. The entire litany there, I think, can be really clarified and strengthened. And that's a huge opportunity we have right now.
Thanks, Kaylan. Mary, from your perspective with Family Connects, where are the greatest opportunities?
I think I can think of a few opportunities, and just kind of to build on what Kaylan said, we've got a tremendous opportunity to learn from the Family Connects pilot counties. We're learning from them as we go about what it takes to really launch a regional approach. So for one county to be the host and be able to cover or assist with coverage in the surrounding counties, and also what it takes to set up those partnerships with hospitals and health departments during a pandemic, and to pull together their community advisory boards and launch an initiative in a collaboration with the Smart Start agency. So, you know, we're doing this for 3 years, we're piloting it, we're learning. And so the goal is to take it statewide, but in order to do that, we will need to be able to tell the story. We'll need to be able to gain Medicaid coverage for the services and get buy-in from the private insurance companies. We'll also need additional funding. So I think we've got a tremendous opportunity here, which I think would be wonderful for meeting families right when they have a baby, and relative to what we're doing here with the HPPE Summit, really to start that continuum of care. So you're meeting families right when they have a baby, you're supporting them, welcoming them, helping connect them with resources, and then connecting them with these other amazing home visiting programs and parenting education programs that all of you all are working on. So I think it's just meeting those families right at birth and then helping along the way makes total sense to me. So it's a tremendous opportunity.
It's really exciting to hear about all these opportunities. And I heard a lot of themes of advocacy, storytelling, linkages to systems, and the importance of care coordination, particularly with pediatric offices. So thank you all for that. Mary, I'm going to go back to you to start so that we're not always going in the same order. And we're going to switch now to talk about where the gaps are for supporting young children and families, and how can we close them?
Sure, thank you. So I also have a lot of gaps and challenges that I could mention. A couple of them are with mental health support, just in thinking in practical terms of what's happening on the ground right now with the nurse home visitors with Family Connects. And probably you all are seeing it. I think even in normal times, there's the mental health support that's needed for new parents, and especially now everyone's dealing with it. But there's definitely a gap there and we need to do something about that. There's also a gap with lactation support for new parents. On another very practical level, just gaining hospital floor access for Family Connect specifically has been difficult, as you can imagine, with COVID. And we know that that's the best way to reach families is right when they have the baby and where they have the baby. And then the nursing infrastructure right now is really difficult. As many of you may know, there was a nursing shortage before, and now it's even worse, and now it's highly competitive. So nurses can go and become travel nurses and make 3, 4, or 5 times as much as they're making doing anything else. So it's been difficult for the pilot communities to hire nurses and also to retain nurses. So that's something that is happening right now, that we're dealing with right now. And then, so just more of the infrastructure piece, there needs to be a focus on recruitment of nurses and competitive pay for home visiting nurses specifically. And then also recruiting nurse home visitors that are from diverse backgrounds, that are representative of the families that are being served. And then I would also just say, back to what I was mentioning before, that continuum of care. So the navigation piece of really helping families. You know, we all know how hard it is when a family has to go from agency to agency and try to piece it together. And if there are transportation issues or parenting issues or a single parent, to really have that navigation piece it's a gap, and it's also a really great opportunity for us right now. Thanks.
Great. Kaylan, from your perspective, where are the gaps and how can we close them?
Such a good question. I want to lift up everything Mary just said, because those are, I think, the biggest things. We have a huge provider shortage across the state. I think it's also really important to think about, when we think about that network adequacy and who can be reimbursed through Medicaid, how geographically stable is that network as well. Like, we don't want people to have to be connected to further supports that are 30 miles away from them and they can't meaningfully access. But we also know that we just simply don't have enough providers to meet the needs of the families that we have currently. So how can Medicaid support that? You know, money is money. You got to be paid for this work. And you have to be paid appropriately. I totally understand why people are leaving, because they're looking at other opportunities. We are in a rough situation because of COVID. We were in a rough situation before that, and our economy is not getting easier. It's getting a lot harder to sustain. So we've got to come up with quite literally the monetary solutions to address those issues, so that we're not constantly seeing the pendulum swing for when we have providers versus when we don't. I think the other thing that I would be remiss in not bringing up is quite literally the coverage gap. So we have families getting supports right now, but what happens when they lose their eligibility under Medicaid? Because we have not expanded Medicaid, we are dropping parents off into a pit, essentially. Unless they're able to support themselves through plans on the marketplace, which are often way out of reach for most families. Financially, there aren't very many other options until we can expand Medicaid in this state and make sure that parents have the coverage they need, because we know when parents are covered, their kids are more likely to not only be covered, but utilize the coverage that they have. So that is a really big piece that we just need to keep kind of beating the drum. I know it's been like well over a decade at this point of trying to get that done. We're feeling fairly optimistic that this joint legislative committee that has been started up at the General Assembly is going to be used to find ways to close that coverage gap, ideally through Medicaid expansion. There are some, potential federal options floating around. But I think the messaging there is really, we need sustainable coverage opportunities for every single North Carolinian, and that can only come by way of expanding Medicaid so that it catches more folks, so that we're not seeing peaks and valleys of coverage opportunities. So to me, those are the really big things. We always need to be asking the General Assembly to put their money quite literally where their mouth is. They talk about wanting to support families and children often, and we are not seeing that translate into dollars. We need sustainable funding. It needs to be a line item in the budget every time we have a budget, God willing. And we need to make sure that we're also not seeing a huge infusion of dollars one year and then nothing the next year, because that is not going to get us to sustainability. If we're thinking about this, as we should be, as part of preventative care, there needs to be a foundation of funding that supports that, and the access to that kind of hinges on how much money we can pay people, what the coverage options are for families long-term, and making sure the system is kind of fiscally solvent so that we're not losing out every couple of years because of fluctuation in funding.
Thanks, Kaylan. Deborah, where are the gaps and how do we close them from your perspective?
So I would say the biggest gap is we need a continuum of prevention services that support all families. And so this means a variety of services that are supporting families with different needs. So, I really personally feel like every family could benefit from parent education and home visiting, but we know that some families come with minimal needs and some families come with great needs. And so we definitely need to have that continuum. And we also need to offer families a variety of different evidence-based models, so that they can choose what's going to work best for them. We have some programs that are 16 weeks long, and that is not what's always best for every family. Not every family can commit to that much. So we need to meet families where they are, and offer something for everyone. And in addition, these services need to be available throughout the state, and they need to be delivered in a supportive, non-stigmatizing manner. So basically right now, what we do is we have X amount of dollars, and we put out a competitive request for applications. People apply, and often the best applications are awarded. And then they serve their county or their community. And so we've got scattershot throughout. And folks, I really do feel do an excellent job in the services that they provide, but you could live one county over and not have access to a service. And we want to really make sure that that is not the case. And when I talked about a continuum and non-stigmatizing, I feel like family resource centers really offer a great opportunity to provide these types of services, because you can be a grandparent taking care of your grandchild and go to a family resource center and no one knows that. No one knows that this child's family has been involved in the child welfare system. And so you are involved in services with other parents, and it's not, honestly, it's not stigmatizing. It's not a big deal. So that's the main thing, is that we want to have options for family. And when I talked about some of our federal funding, in particular the CB CAP and the Promoting Safe and Stable Families federal funding streams, they do provide services. Well, they provide funding for services for families who are not involved in the child welfare system. But it's small. It is a small amount of funding. And if we want to make sure that we're serving the entire state and every family who wants these services or needs these services, we're going to need to develop alternative sources of funding to create an effective continuum.
Thanks, Deborah. And Greer, where are the gaps and how can we close them? And you and Rebekkah can tag team this if you'd like.
I'm going to let Rebekkah go. Thank you.
So I'm everything I've thought about has been mentioned before, but so nationally, home visiting wages and benefits are extremely low, and home visitors are leaving current jobs because of this, finding higher paid positions, and then we're seeing that when this happens, families then disengage because they've spent this time building trust, and so they often disengage and drop out of the program. So, you know, more benefits and more wages, higher paid wages in home visiting would be very helpful. A lack of resources is a huge support gap, like housing, transportation, mental health, like you mentioned before, affordable daycare vouchers, safe, intimate partner violence housing, just to name a few. So we need more resources in all of 100 counties. And just like Deborah was saying, you know, you can be in one county and then the next county over not have any services whatsoever. The rural counties struggle in finding, I came from a rural county, so I know this, they struggle in finding the local resources, even within 25 miles of their service area. So we need more collaborations and support with programs like NC Matters that offer online and phone support for maternal depression. We also need to promote NC Care 360 and helping with areas and locating resources and things like that. And then I wanted to mention too, stigma is hard, and oftentimes our families come from a place where child protective services might have been in their own families, so they're sometimes hesitant to enroll. They don't know what home visiting is all about, and so often they feel like they've done something wrong or they're seen as unfit, and just normalizing home visiting and would just help in making this a better experience for everybody. So
thank you all so much. You all raised some really, really important issues, and I'm really struck by how there's been a national conversation about the need to address wages in childcare, but we really haven't talked about it and had the attention in this sector, in home visiting and parenting ed, and really about nurses. And we've known for years that the availability of nurses for programs like Nurse Family Partnership is limited in many of our rural communities. So that's something that we can be talking about as a system, in the system design, in our communications work group as well, and continuing to lift up that care economy, the coverage gap, continuum of services, and every single one of you talked about concrete economic supports for families being a real key to closing these gaps. So thank you for raising all of those. I'm going to switch gears a little bit, and we're going to speak specifically about MIECHV and families first, and really want to hear about the challenges we face in leveraging these opportunities for children and families. Greer, can you talk about those challenges in leverage for MIECHV?
Sure. So due to flat funding, there's been diminished spending power with MIECHV. Pre-pandemic estimates show that MIECHV reached only 3 to 5% of eligible families each year. The 2020 North Carolina MIECHV needs assessment identified new at-risk communities that would benefit from MIECHV, but they cannot be established until additional funding has been made available. And this next part is pretty much what Rebekkah said. Home visiting programs frequently identify recruitment, retention, and high turnover of home visitors as one of their key challenges to adequately serve families.
Thank you. What are the big challenges with Family First, Deborah? This is a big new opportunity and a big system change for child welfare. Can you talk to us about that? Deborah? Well, we may have lost Deborah. And I'll just say very quickly that, you know, Deborah talked about this at the beginning, but we don't have a statewide standard for a lot of programs yet in North Carolina in that child welfare system. So this idea of being able to offer parents as teachers and home builders, for example, in a way where it's accessible to all families, no matter where they live, will be a large challenge in thinking through how to help those social services agencies access the community-based organizations who may be able to better deliver them in a destigmatized way, I think will be a huge part of that challenge. And hopefully we'll get Deborah back in a few minutes. And if we do, we can come back to that question and ask her what she thinks.
I'm
Deborah?
sorry, Sharon, I'm here.
It's okay. Okay. Can you talk more about the challenges in leveraging the Family First Prevention Services Act?
Oh, yes, I can tell you about that. So first of all, like I mentioned, Family First is tertiary prevention. It only serves children who are at imminent risk of being placed outside their homes and their families. It doesn't help that much to strengthen or support families before a crisis occurs. There are a lot of administrative requirements. It requires specific evidence-based programs, as well as a plan that has to be submitted and approved by the Administration for Children, Youth, and Families. It requires a state match. It requires a continuous quality improvement process. And without a waiver, you can request a waiver from the federal government for a rigorous evaluation if the program is on their clearinghouse and it's rated as well supported. That's another reason we're starting with home builders and parents as teachers. But without that, you have to have a rigorous evaluation plan as well. And so those are real barriers. And then I will say our state process in terms of setting up programs and contracting, and we have the strictest IT requirements in the entire country. All those things we create more administrative burden to actually getting programs up and running. And I think I heard Sharon mentioning this. Also, currently, all of our services that we offer at the Division of Social Services, whether it's a county child welfare agency or whether it's one of these prevention programs that is provided by a community-based organization like a nonprofit agency, they are all structured to serve communities, counties. That's their model. And it's going to be a real challenge to shift that to a regional model that's going to cover the entire state, because we just don't have the mechanisms at this point to do that, and we're going to have to build them. We have a state child welfare reform called Ryland's Law that required the state to develop regions. North Carolina is one of a handful of states, 8 to 10 states, that is state supervised and county administered. And that means that we have 100 counties and we have 100 different ways of doing things. And kind of like North Carolina Partnership for Children, we provide guidance to them. When the federal government comes and evaluates the state, they are evaluating the state, right? But we don't actually have the authority to make everyone do the same things. So other states are state run. It's much easier for them to do this. And they may have hubs. Kansas has hubs where they could easily develop these family first services and reach out from there. But we're going to actually have to make a concerted effort to shift from a county model. Like we're not going to change that. I'm sorry, I just want to be really clear. The state is not going to change the fact that all 100 counties are independent, but we have to have a way of reaching these families regardless of where they live. So that is a really important consideration. I mentioned earlier that family resource centers offer a great opportunity to provide an array of services to all sorts of different families. We know that the federal government is really excited about family resource centers. However, they are not typically equipped to run a region that may have 10, 12, 15 counties in it. And so that is also going to be challenged. I mean, we have currently we have a contract with McDowell County Schools. McDowell County is fairly rural, they have 3 family resource centers that are operating within that county providing this service. So that's just kind of, for me, an illustration of the challenge of how do we offer these services regionally so that every family has access using a model that is really hyper localized. So I feel like there's a lot of things that we need to figure out still, Sharon.
Absolutely. Thank you all so much for helping us think about that. Now we're going to talk about what federal, state, or local issues you all see impacting North Carolina's home visiting and parenting education services. How is your work specifically impacted? We'll start with you, Rebekkah and Greer.
Thank you, Sharon. I'll answer that one. With MIECHV, obviously it's the reauthorization. It needs to be passed before September 30th, 2022. Last time there was a 6-month lapse, and in that case, there were home visitors that resigned because they were not sure about job stability, and this left family without the needed supports and eventually could lead to disengagement. So it's very important that the reauthorization goes through before it expires, so we can keep as many families in the program as possible.
Great. Kaylan, where do you see the issues at the federal, state, and local level?
So I think there are several, especially at the state level. So while I've been talking about the opportunities that can come from managed care and some of the transitions and transformation in Medicaid that North Carolina is undergoing, that also creates an obstacle because we are basically doing a systems overhaul to make these transformations happen. And so while we hope that more coordination can happen, we know that the state is kind of strapped for capacity in doing all of this transformation work. So we're going to see in December the launch of the tailored plans, and then we're going to see in the next summer of 2023 the launch of the foster care plans. And all of those should have some connection to home visiting and parent education services. But my concern is it's going to be lost to the wayside because of just what it means to have systems transformation like this. It's a huge overhaul. We know DHHS is already, doing their very best, but they have limited capacity between all of this overhaul, the fact that COVID is still going on and we don't know what that's going to look like, and just trying to get everything kind of up and running and integrated. The other big piece of it, I think, is that back-end systems integration. I don't think that there is a single state that has really figured that out whole stock. So that's also a huge need we have, and there's not really a great blueprint or roadmap for us to lift up. And we know that that is just a difficult sell to make, both to the state departments and to the General Assembly to fund that. It is hard to say, no, trust us. We need a bunch of money to do this thing, but we're not entirely sure what that's going to look like yet or how we're going to do that. And then I think one of the things that's happening both on the federal side and that will impact the state side is the impending end of the public health emergency. And I say that because what that is going to trigger is eligibility redeterminations. And for the folks that are covered by Medicaid, there is a likelihood, depending on how, nobody has had to reapply or show that they're still eligible for Medicaid in over 2 years at this point. We are going to see people who are eligible be dropped from coverage, which is going to mean that they're dropped from services that they're getting or these services that they will be needing. And so we're just going to see a disruption of coverage. I think that the state has every intention to do this as thoughtfully and systemically and safely as possible, but we know that redetermining our entire Medicaid population is a huge undertaking. And yes, the federal government is trying to pass laws that would help states kind of minimize how many people can be redetermined at once. But when you think about how we have splintered eligibility across all 100 counties here, some counties are going to be better equipped to serve those families and make sure there's a continuation of coverage that's seamless than others. And so we're also going to likely see some more geographical pitfalls that families will fall into with their coverage and therefore the services that they're receiving. And so all of that is going to kind of come together at once, unfortunately, and just be what it is at the state level. We can't really stop that train from rolling through, but we have to be really thoughtful and mindful and understand that all of these things are connected, even though they might feel a little esoteric, because you're probably not sitting around like I am thinking about eligibility redetermination. But when you think about that from an access point of view, you really can understand and walk backwards why that is so important. And that's coming down the pike for sure.
That's a big one, Kaylan. As someone who used to work at a local DSS, I know that that's a really big deal. Deborah, from your perspective, what federal, state, or local issues are you seeing impacting the services, and how is your work impacted?
So I already mentioned some of these issues. The Federal Family First Act only allows for a limited range of evidence-based programs. It focuses on a narrow population. It has a lot of administrative requirements. In terms of the other funding that focuses on, a broader range of families in primary and secondary prevention, it's very minimal amount of funding. It can only serve a small amount of families in the grand scheme of everything. And then the state has a lot of red tape itself in accepting money and distributing money. And so I think all of those are issues that are going to impact how quickly we can provide these services. How much match we have from the General Assembly will also tell us how many families we can serve. So in order to create a broader continuum, we're going to need to braid various funding sources together. So those are the things I see like on the federal, state. And also in terms of the local is we're going to have to be able to provide services everywhere. And there are some places, we've touched on this in this panel, that are easier to do that or more difficult. So in order for us to provide services in particularly rural areas, not only do we need the staff to be able to do that, but there have to be enough families that need service that it is viable for the agency that is providing the service. So, a lot of these services are, you need a critical mass in order to be able to afford to do this, even when there is a funding source. So I definitely think there are some things that need to be worked out. And Sharon, I also wanted to mention there is a question in the question and answer that I just wanted to answer at this point, where the question is regarding Families First with 0 to 3 healthy steps approach of embedding a social worker in practices that address social determinants of health be worth exploring. So the first thing I want to say is there is this Title IV clearinghouse for evidence-based programs, and this particular one, Healthy Steps, is not on the program. It's not on the clearinghouse. They do make a commitment to evaluate and assess programs continually. So it does, just because it's not on the list now doesn't mean it won't be in the future. But if it's not on the list, it's very, very hard to put it in your plan and get the federal government to approve it and reimburse for it. So that's one issue. But in terms of the idea of looking at social determinants, I think the protective factors really plays into that, and everything that we do at the Division of Social Services in terms of prevention is based on protective factors. And if you're looking at social determinants of health, you're looking underneath and you're looking at what are the things that families need to thrive. So you're not just treating the symptoms. And I think we realize that in child protective services, that like symptoms that children present, like a behavioral issue, could be caused by a whole variety of things. And if you're not really looking at the social determinants, you're not really helping that child and their family. So I'm going to hand it back to you, Sharon.
Great, thanks, Deborah. Mary, we haven't heard from you in a while. So tell us what federal, state, or local issues you see impacting the home visiting and parenting ed services, and how is your work, particularly with Family Connects, impacted?
Sure. Well, as Kaylan mentioned, the funding piece is glaring. We're going to have funding. It's going to be expensive, but I think we all know that it's worth it. So there's the funding piece that's definitely a big issue after this pilot program is over. So making sure that we've got the private insurance companies, Medicaid, and then additional funding on board in a collaborative effort is going to be really crucial. And then another piece that I think is really important is knowledge. I think that I mentioned before, but with this HVPE work as a whole, I think we really are going to have to make sure that we're focused more on connectivity of services versus competition. So realizing that there are more families than can even be served is really important for us to know. There's work for everyone. Families need so much. And so if we can, with the help of the HVPE committees and board, can pull together our stories to show why this continuum of care is so important and how one program feeds into another program, and that we're really offering families this continuum to be able to thrive, I think is going to be really important. And I think this is a great next step, having this summit and then the continued work from there. I would also say that part of that connectivity is, someone mentioned it earlier, is the NC Care 360. So it's a really tremendous opportunity that's there. And I think in some counties it's being used a lot and everyone's on board and it's working. But in many counties it's just not there yet. And so I think having the infrastructure there for NC Care 360 would be really beneficial for, I think when a nurse home visitor goes in after the birth of a baby, and then they're able to make the referral to a pediatrician or to an early childhood center or to DSS or wherever the family agrees to have the referrals shared, I think would be really important. And to have that system is there. And I think that it has just a ton of potential if we can get the folks on to use it. So if there's just a couple agencies in a county using it, it's not going to work. I think it would be really great to see some more focus and funding in that area as well to really get up and running. I think it would help everyone on this call and most of the agencies doing work with and for families.
Thank you, Mary. I heard lots of overlapping themes that included capacity at all the levels, particularly the system transformation capacity, staffing capacity, including the Medicaid eligibility redetermination capacity statewide, sharing knowledge, connectivity, and then, the theme that we hear throughout all of your answers has been around advocacy and storytelling. So those things, we're hearing that over and over again, and this is going to be really helpful to us as we continue to build the system and do the work in our work groups. I'm going to switch gears now and talk about future opportunities and our vision moving forward. So what opportunities do we have to engage more families and to highlight the importance of home visiting and parenting education supports to state leadership? And we'll start with you, Mary.
Okay, thank you. Well, just kind of following up on what you just mentioned, the storytelling, I think family voice is critical to this work. And so we can tell our stories as agencies and home visitors, but to have family voice at the table is absolutely critical to get the message across. Because if you think about it, once you have been through a service, just how I was able to tell my story about a home visit, I'm able to advocate for that. So as families participate in your programs, they are able to talk about the benefit and how it helped them. So I think being able to really harness the power of families is really important. And I also realize some other work that I do within CPC is around family engagement. And so also realize not everybody knows how to get family leaders to the table or to talk. And so little side note, there are some free resources on NCPC's website, and I can put the link in the chat in just a little bit. And it's about family engagement. We did some work with Moms Rising to create some materials on how to get family leaders to the table that represent just a diverse population in your communities, and then how to pay them well for their time and how to help them to understand their stories and feel empowered to share. So I think that is really important at the programmatic level, at the local level, the state level, and even the national level. They can give feedback. Parents can give feedback on programs and services that we are all offering, which we need, because we need to know, is it working? Are people benefiting from it? And if not, what are the suggestions from the parents on how to change that and make it better? They can also be champions for their children and other children. They can recruit other family leaders to the table, which we're seeing in some of our family engagement work. So they're champions also. And really they can and should be on any committee or board where any decision is being made for families. They have to be there. So I would encourage everyone to invite them, not only for a survey or to give feedback, but really invite them to the table in decision making. And then I would also just say that the NC Care 360 platform could really make a difference when we're talking about a robust referral system.
Great. Kaylan, from your perspective, what opportunities do we have both to engage more families, but particularly to highlight the importance of home visiting and parenting education supports for state leadership?
Absolutely. So I wholeheartedly agree with Mary. Those who are closest to the issues get to find the solutions, or at least co-create them, and they get to be paid for their time doing that. And I think that needs to happen within the State Department, that needs to happen within the PHPs and managed care organizations. We need to be working hand in hand with the folks that are using this benefit and using these services. I think there are so many opportunities for home visiting and parent education services to be a natural entry point for so many other referrals. And right now it feels like almost the inverse of that, where it's like an ad hoc, depending on who you connect with, depending on how you enter the system. I don't think there's cohesiveness in that. And I think that the folks that have this lived experience can help us figure out how to navigate that better and how to create kind of sustainable bridges that come from a no wrong door approach to these services, to all of the other things that family and child is going to need to be able to thrive and live a life with dignity. The other kind of wonkier sides of things, I know I sound like a broken record everywhere I go, but we have got to stop kicking the can down the road on system integration. We just have to demand it. We have to demand that funding goes to it. We have to make sure that all of the systems are working together to support these children and families, so that they're not getting care coordinated to within an inch of their life between 10 different systems, because that's not doing anything productive for them. And so that we can have reliable feedback loop and communication on what this child and family is getting and how it's supporting them and how we can move them into the next phase, so that they're not being dropped from services only to pick them up a month later and have things be disconnected, or getting services in one space and supports and not having other providers who are working to integrate their care know about that. Families are already far overburdened and often underserved. And so to put that level of management and coordination on their plate is a huge disservice to their ability to actually be able to do things like raise their kids and hold down a job and live their lives, because we're all entitled to that. And so I think that is a big piece of advocacy that is going to take an all hands on deck approach, because it is a hard problem to solve. But if we're all singing from the same hymnal, we're able to at least show this is a real need. And then I think the other big piece of advocacy is needing to show up and show our General Assembly these services are so meaningful. They are preventative. They help us stave off chronic conditions. They help us meet people where they're at and get the services they need. And that saves money down the road. And I know that's what the General Assembly is often tasked to think about. And it is unfortunate that we're still stuck in this kind of situation of thinking about only the immediate and short term. We need to help people finally get to the place where they're thinking 10, 20 years into the future. What we can do with the cost savings and what we would have as communities that are truly supported and able to thrive would be an entirely different world than trying to just save a dollar here or there year after year. And I think that just takes the kind of developmental perspective that so many of us bring to this table, because we're doing this work and we think about things from the developmental standpoint. But that is not, as we know, the typical response and thought patterns of the folks that are in power often. And so we just need more voices from providers through families to show this is immediate and long-term, and it's critical for us to hold both in our heads at the same point as we figure out how to invest. It's an investment that is going to pay off, but we really need more people to be stepping up. And I know it's hard because I know we all work a ton, and the last thing we want to do at the end of the day is call our elected officials or try to get a meeting with them. But the more they're hearing about this from the people in their district, and the more it's coming from a story and not from a like, hey, we need more money, because that's just a hard sell. But the more they can see the human piece of it, and the more they can see that this is an investment in prevention, I think the better off we will be in actually getting this done. So that is my big pitch on everybody being an advocate.
Thank you, Kaylan. You're singing my song, and you're, at least with me, you're preaching to the choir about the importance of investing upstream. We talk about it all the time at Prevent Child Abuse North Carolina, that we know that the return on investment for all of these programs is extraordinary. And it's not just in the dollars that we're going to save, but it's going to be an improved health and school success and less criminal justice system involvement. We're going to save a lot of money if we invest in this, and we need more people saying that. So thank you. I'm going to take us to our last question, because we have a little bit less than 10 minutes left, because we want to really be talking about our vision for these initiatives as we finish up our time together. So, and I'll start with you, Rebekkah and Greer. What is your vision of success for these initiatives and others working together to better support children and families? What's the dream?
The dream would be for home visiting in all 100 counties. Obviously, that's something that is needed. And again, for MIECHV, the success would be the continuation of the MIECHV home visiting program without interruption. Continue to allow virtual home visits with model fidelity. This has really helped keep parents engaged during the pandemic, and it essentially reduced travel time for home visits. This flexibility also allowed for fathers to be involved with home visits, which is very important. And again, we just need to normalize home visiting as a needed support and resource for families.
Terrific. Deborah, what's the vision from state DSS perspective?
So our vision of success is that North Carolina communities offer a variety of equitable, affordable, and accessible home visiting parent education programs so that families can choose to participate in the programs that best meet their needs. In addition, we'd like to see communities promote these parenting programs in addition to other family-friendly policies as a non-stigmatizing means to support families and prevent child maltreatment.
Terrific. Mary, from your perspective, what's the vision and the dream for Family Connects in the system?
Yes, so I mean, immediately, well, soon, we'd like to see legislation passed and funding in place to be able to offer home visiting for every family. I think the grand vision would be a coordinated whole family system that is there for families when a mom is pregnant, so right when it starts. And so every family has the care that they need from prenatal on, and that there is a coordinated system to help these families move through other supports and resources that they need. And that there are those resources and supports in every county throughout the state. So that's what we know families need to thrive, and I think that we can get there.
Kaylan, what's your dream for these initiatives working together?
Well, my real dream is universal care, y'all. To be completely honest, that's the only way that we're able to really get this done sustainably for everyone. But until I live in my dream world, I think the more immediate and maybe tangible dream is that we are able to provide reimbursement to providers at a much higher level so that they can have quality of life for all their incredible work, and that this funding is sustainable, that that it is an investment, as we were just talking about, that the state is taking, so that these services are a part of a typical referral stream, that it is something that is kind of seen as normalized, as Greer was just talking about, that we are able to fold these into a continuum of care so that it's both speaking to the needs of now and prevention to the future. And that we are, Diane, I saw what you lifted up in the chat, able to have these conversations cross system. So NC Child is, we have a campaign, basically it's a campaign, it will be a campaign called Early Well, which is looking at infant and early childhood mental health. And I'm sure many of you have either heard of it or been part of it. But it's one of the first kind of stabs at this cross-system collaboration. And that's what it's going to take. And those are big conversations to have. Those are not easy conversations to have. But the more we can intentionally come together and talk about how all of this is mutually reinforcing to child development and well-being and family well-being, and in turn, all of the well-being of our community and our state, the more we can move forward in the same direction, because we all want the same things, but we need to figure out how to do it together in a cohesive way. Admittedly, the state is not necessarily set up for that, just given the infrastructures that we have. But I think that there are so many opportunities for us to be able to create those bridges together so that we are not trying to address one piece over here and another over here. It's got to be a cohesive push. So that's really my dream, is that we start rolling up our sleeves and doing some of that more nitty-gritty work together so that we are able to show this as a unified front and really bring that to the decision makers of the state.
Thank you all so much. This has been a really inspiring morning to talk to all of you, brilliant and passionate advocates for these programs, and to share your perspectives. I'm hearing a lot about lifting up advocacy, sharing stories, normalizing programs and supports for all families, universal care, the need for reimbursement and sustainable systems. And I think there's so much promise in this home visiting and parenting education systems work that we've been doing, bringing folks together across divisions within the Department of Health and Human Services with advocacy organizations, really want to encourage everyone to continue this conversation in your communities, to connect with these folks, connect with us at Prevent Child Abuse North Carolina. I know Malia Rose Waters, our policy director, has put her contact information in here as we think about ways that we can advocate for these programs and share stories. This work is, while we've been at it for a few years now, more than 3 years in developing the system and creating our governance body, it's really just beginning. And you all have put out an incredible vision that now that we've put it out in the universe, I believe that we can make it happen. And it's going to be maybe something that doesn't happen very, very quickly. It's going to take us a long time, but I believe a decade from now, we're going to be in a very, very different place than we are today, thanks to the good work, the vision, and supports that are being created by all of you right now. Thank all of you for paying attention to us for the last hour and a half, and I'll turn it over to the folks at NCPC for any last comments about getting to your next session. Thank you all so much.
Yes. Thank you all for joining us. Our next session will be our parent panel, and it begins at 10:30. So we hope to see you there. Additionally, we are posting a survey link in the chat, and we would love it if you could provide feedback to us for this session. So again, thank you so much for attending this session.